In this capture, we're going to examine the GI anatomy, physiology, and assessment. Many of the things we talk about will be review of concepts, things from fundamentals and from A&P, but if it doesn't sound familiar to you or I'm emphasizing a particular point, do make sure you take a look at that in the required reading. So to start with organs of the GI system, we're going to go from top to bottom. We start with the oral cavity. We have saliva that begins to digest food, soften the food, and then it goes down the esophagus. We're going to focus a little bit on the esophagus in class and in the subsequent captures, specifically with the disease process of gastroesophageal reflux disease, or GERD. And we'll talk about the area of the esophagus, the lower esophageal sphincter, or the LES, and how when it does not work properly, that's what allows gastric contents to reflux up through the esophagus. Between the esophagus and the stomach, that's where that lower esophageal sphincter is. Once food gets into the stomach, this is where a lot of your digestion takes place. This is where your hydrochloric acid is, your pepsin, and we're going to talk about acute gastritis, and we're going to talk about ulcers and how those play a role in disease processes of the patient when you see problems with the stomach. We won't talk about things such as stomach cancer per se. You'll kind of hit that in the second year, although we'll mention things like that briefly. Moving outside of the GI system to the accessory organs, we're going to talk a little bit about the pancreas and a little bit about pancreatitis, only in the sense of how it relates to gallbladder disease and common bile duct obstruction. Actual pancreatitis, you're going to get into next year with Mrs. Hyatt. But if you think about the pancreas, not only does it produce insulin as an endocrine gland, and part of this unit does talk about diabetes, but it also has some exocrine properties where it produces amylase and lipase, digestive enzymes, that then go down through the cystic duct into the small intestine to help with nutrient digestion. We'll talk a little bit about the liver, again in direct relation to gallbladder disease, but getting into things like hepatitis and liver failure, that'll be your second year with Mrs. Faust and Mrs. Hyatt. We will talk extensively about the gallbladder because one of our focuses is gallbladder disease. We all know liver produces bile. The bile goes to the gallbladder where it's stored and concentrated, and then it's excreted from the gallbladder in response to fatty meals to help with digestion. Back into the GI system, we'll talk a little bit about the small intestine, particularly peptic ulcer disease. The small intestine, if you kind of think about the three areas of it, you have the duodenum, the jejunum, and the ileum. And the small intestine is responsible for absorption of nutrients. So when we start talking about disorders of the small intestine or a patient that's had surgery where part of the small intestine has been removed, we always get concerned about nutrient absorption and the possibility for malnutrition. Finally, we have the large intestine. That is going to be responsible for the absorption of water. And that is going to be very important when we talk about colorectal cancer and surgery related to colorectal cancer. Because the farther the food moves in the large intestine, the more water that gets absorbed, and that's what makes our stools look the way they do. So that was pretty much just a basic review of that. Let's switch gears and start really talking about assessment of the GI system. Again, a lot of this is foundational content, but it is a good review. For health history, you really need to make sure you are asking about both past medical history and past surgical history, and being very specific in what you're asking. You know, have they had a history of reflux? Have they had a history of abdominal surgeries? Do they have diabetes? Because when we talk about gastroesophageal reflux disease and the way things move through the GI tract with peristalsis, patients that have had diabetes for a long time can experience what we call gastroparesis, which is delayed gastric emptying. You want to pay attention to medications that they take, and I do want to emphasize over-the-counter medications as well. There are a lot of meds that can cause GI issues. There are also a lot of medications available over the counter, such as Prilosec and Prevacid, and many times we'll have patients who will self-medicate, and they will do that prior to seeking medical attention, so that's really something to pay attention to. Also herbals, because you'll notice when we start talking about the meds in this unit, there is a lot that can interact with your herbal substances. You want to ask about family history. There are some things, particularly colorectal cancer, some of the other types of cancers, some types of inflammatory bowel disease that do have a genetic component. So you do want to know about family history. Most of all, you really need to focus in on their current issue. What brought them in to be seen? How long have these symptoms been going on? When did they first notice it? Has something precipitated the change? Does something make it worse? Does something make it better? And we're going to talk specifically about abdominal pain in just a minute. But the questions that you ask in the health history and in your assessment can be key things to helping us figure out what is going on. For physical assessment, again, inspection, auscultation, percussion, palpation. Just a reminder, you always auscultate before you palpate or percuss, because again, if you auscultate last, your physical manipulation can change the bowel sounds that you're hearing, and then you're not getting a true, accurate assessment picture. You also need to consider some age-related changes that your older adults will experience. They oftentimes will have slowed GI transit, so they have decreased peristaltic times. That can contribute to constipation or more hardened stools. As you get older, that lower esophageal sphincter that I talked about doesn't quite work as well, so you're more likely to see reflux in the elderly. Dry mouth, not necessarily that it's an age-related change, but it's often associated with a lot of medications, particularly if those meds have anticholinergic properties. So you need to think about those age-related changes, and when you're assessing, is it expected? Is there a cause for it? You just want to kind of keep that in the back of your mind. Now, this is what I was talking about before for assessment of pain. Abdominal pain is very nonspecific, so it's important that you really focus in on the location of the pain and if there is any referred pain and what is the location of the referred pain. Because you think about it, the abdomen's pretty big. Think about your underlying anatomy. If you're having problems or pain in the right upper quadrant, oftentimes it's going to be related to the gallbladder, sometimes to the pancreas. If it's down around the umbilicus or a little bit lower, it's generally associated with small intestine. Right lower quadrant, classic, is going to be appendicitis. So it's really important that we focus on where their pain is, but also the description of their pain. Is it sharp? Is it stabbing? Is it dull? Is it crampy? Is it more of an ache? And then also the location. It is not uncommon for patients with severe reflux, and even possibly an ulcer, to present with chest pain. Okay, because the region, it's very close, and oftentimes they're coming in with this chest pressure. The first thing we're going to roll out is cardiac and then respiratory. Then we start looking at GI. But just kind of paying attention to the location of your patient's pain and being very specific in your documentation of that location. So now moving on to diagnostic testing. There are a lot of serum studies that we can do. You guys are familiar with the CBC. Generally that's going to have a white blood cell count with a differential, so never let monkeys eat bananas. We're always looking at neutrophils in particular because that lets us know that there's something acute going on. Looking at the red blood cells, the hemoglobin, hematocrit, that would be important in case there's any type of gastrointestinal bleeding going on. We also look at platelets. Obviously, if somebody has a high number of platelets, they're at higher risk for clot development. If they have a low number of platelets, they're at higher risk for bleeding. We're also going to look at electrolytes, your sodium, potassium, chloride, calcium, magnesium, phos, glucose. Those can be affected if your patient has any sort of vomiting or diarrhea that's going along with their disease process. We also look at BUN and creatinine, again, specifically looking at kidney function. This is necessarily in relation to fluid volume imbalances that may be experienced related to a GI problem. In this particular unit, we're also going to be looking at liver function studies, specifically ALT, AST, alk-phos, and bilirubin. Again, only in relation to how they are connected to gallbladder disease. So when we start talking about cholelithiasis and you have a stone that is blocking in the common bile duct, you're going to see a rise in these enzymes. Pancreatic enzymes, we'll talk about amylase and lipase, again in relation to common bile duct obstruction. We're also going to look at a test called hemoglobin A1C, which is also known as glycosylated hemoglobin. And this looks at a person's overall glucose control for the past 90 days. We'll talk more about that when we get into diabetes. Please, please, please take a look at the lab reference sheet that is posted on Plato. If you came to us from 182, it is the same one you were given in 182. If you don't have it anymore or you need it, it is posted on Plato. You need to know the lab values, particularly the LFTs and the pancreatic enzymes for your quiz. Other testing we have is stool analysis. Yes, we're talking about GI, so you got to get ready to scoop the poop. We can test stool for a number of things. We can look at stool cultures, stool for C. diff. We can look at stools for white blood cells. We can look at the fat content of stools. We can look for ova and parasites. Ugh, yuck. So there's a lot of different things that we can look at within the stool samples. So please, if you have not had experience collecting stool, you need to make sure that you've reviewed that particular process and skill. The other thing that we can check with stool analysis is for the presence of microscopic blood, or you'll hear us call that occult blood or hemoccult stool. Again, we're checking to see is there microscopic bleeding in the stool. There are also radiologic studies. You can have studies that use barium contrast, and barium is a really thick, white, milky, chalky type substance, and it can be used at either end. You can have a barium swallow. Again, the barium acts as a contrast, so it allows for better pictures in radiology. You could also have a barium enema, where they use to actually visualize the colon. Either way, you want to make sure post-procedure you help that client get that barium out. So you want to push oral fluids. If they're on IV fluids, we want to push those. Oftentimes after a barium study, patients will be prescribed a stimulant laxative to help them pass that barium out their rectum. It will cause their stools to be a whitish color. That is expected, so you need to tell your patient that. But the most important priority is getting that barium out of the body. The longer it sits in there, the harder it's going to get, the more coagulated it gets, and it's going to be harder for them to pass that stool. Other radiology tests use different types of PO contrast. You can also have IV contrast, and it's important to understand that when your patient is scheduled for a CT scan with and without contrast, they're referring to IV contrast. And I know we talked about this before in Unit 2. When you're dealing with IV contrast, you need to know your patient's allergies. Are they allergic to shellfish or iodine? If so, it's a problem. There is a protocol, a procedure that we can use for patients that do have allergies to IV contrast. It's called a desensitization protocol, but it involves Benadryl and steroids and H2 blockers to prevent the symptoms. Again, they may use that if the IV contrast is absolutely needed. If not, they'll try to do it without. The other thing you need to be aware of with the IV contrast is your patient's renal function. What is their creatinine level? What is their GFR? If your patient is diabetic, and I know we talked about this in Unit 2, if your patient is diabetic and they are on metformin, that drug needs to be held for 48 hours post IV study. Ultrasound, again, it's going to depend on what area of the abdomen they are using the ultrasound on. If it's towards the top, the patient needs to be NPO. If it's a true pelvic ultrasound, then they need a full bladder. MRI we talked a little bit about before. Again, our issue with that is patients cannot have a pacemaker or defibrillator. Most of your orthopedic implants now are being made out of titanium and they are MRI compatible. But we get concerned about the pacemakers, the AICDs. Also, if they were a metal shop worker or they work around metal, they will often do orbital x-rays of their face and eyes before ordering that MRI, because if they do have any type of metal in their skin, it can actually, or their eye, it can literally suck that metal out. There are also nuclear imaging studies. The biggest one that we'll talk about is the HIDA scan. And this involves a radioactive isotope that's injected and then medications given to stimulate the gallbladder to see how well it's working. Finally, the last thing of assessment we'll talk about is endoscopy. You can have an upper endoscopy or an EGD, esophagastroduodenoscopy, or they can have a lower endoscopy, a colonoscopy. Okay. Again, this is going to involve using a scope, inserting it down or up the GI tract, whichever way you're going, to actually directly visualize the tissues that are in there. They can take biopsies and samples with these procedures. With colonoscopy, if they identify polyps, they can actually remove polyps depending on their size and location. So when you think about prep for these procedures, if it's an upper endoscopy, they're going to have to numb the gag reflex in order to get that scope down. Patients are also sedated for these procedures. So again, upper, think about the gag reflex, think about safety post-procedure. For the lower endoscopy, obviously this patient's going to need a bowel prep prior to this procedure. Also, one of the risks of that is perforation of the colon. So we want to watch for any gross rectal bleeding. We want to make sure they're passing gas after their procedure and that they're recovering from the moderate sedation. So that's it for anatomy, physiology, and assessment. The next capture is going to focus on treatment modalities.